Hello, everyone, and welcome. Today, we'll be diving into the assessment and concepts of care for patients experiencing pain. Our goal is to enhance your understanding and skills in providing compassionate and effective pain management. Let's start with the core concepts. The priority concept we'll focus on is, of course, pain itself. We'll also explore interrelated concepts like comfort, cognition, and sensory perception, all crucial in understanding the patient's experience. These concepts are deeply intertwined. For instance, when pain is unmanaged, it can affect how a person thinks, cognition, how they perceive the world around them, sensory perception, and their overall sense of comfort. So, understanding pain requires a holistic view of the patient's mind and body. Here's an overview of what we'll cover. Pain is a primary reason people seek medical care. It's a universal, complex, and personal experience. Failure to manage pain is a global health issue, impacting individuals, healthcare systems, and economies. Think about how pain affects work productivity, quality of life, and emotional well being. Poorly managed pain leads to longer hospital stays, increased costs, and can even affect a country's overall public health outcomes. Let's define pain. It's an unpleasant sensory and emotional experience linked to potential tissue damage. Importantly, pain is whatever the experiencing person says it is, existing whenever they say it does. Self-reporting is the most reliable indicator. This definition reminds us that pain isn't just physical, it's emotional and deeply subjective. That's why listening to patients and trusting their words is essential, even if there's no obvious physical cause. Pain can be categorized as acute or persistent, chronic. Acute pain is short-lived, often from trauma or surgery. Persistent pain lasts beyond the expected healing time, with persistent non-cancer pain being the most common type. Persistent pain isn't always visible, and patients may suffer silently. Recognizing these types helps guide appropriate treatment and prevents unnecessary suffering. We can also classify pain as cancer pain, which can be acute or persistent, or by its underlying mechanism, nociceptive or neuropathic. Understanding these classifications is key to effective treatment. These classifications help providers choose the right interventions. For example, neuropathic pain may not respond well to standard opioids and might need other types of medications like anticonvulsants. Acute pain serves as a warning sign, activating the sympathetic nervous system. This triggers fight or flight responses like increased vital signs, sweating, and restlessness. Recognizing these signs is crucial for prompt intervention. Remember, the absence of physiological or behavioral responses doesn't mean the absence of pain. Acute pain is usually temporary, with a sudden onset and easily localized. Sensory perception changes as the injured area heals. Persistent pain lasts or recurs for more than 3 months. It has a gradual onset, and its character can change over time. It serves no biological purpose and can lead to emotional, financial, and relationship burdens. Chronic pain can become a disease in itself. It affects how people sleep, interact with others, and even their ability to maintain employment or enjoy daily life. The body adapts to persistent pain, making it a global health problem. Conditions like diabetes, rheumatoid arthritis, and Crohn's disease can contribute to persistent pain, impacting quality of life. Managing these conditions isn't just about controlling the illness, but also about treating the pain they cause. This improves patient function and satisfaction. Cancer pain often results from tumor growth, nerve compression, or metastasis. Cancer treatment itself can also cause acute pain through procedures, surgery, and toxicities from chemotherapy and radiation. Procedural pain is associated with medical procedures or surgical interventions. It's usually acute and requires careful management to minimize patient discomfort and anxiety. Examples include needle sticks, wound dressing changes, and catheter insertions. Anticipating this type of pain allows nurses to use preemptive strategies like topical anesthetics or relaxation techniques. Pain can be categorized by its underlying mechanisms, nociceptive and neuropathic. Nociceptive pain involves normal pain processing, while neuropathic pain involves abnormal processing due to nerve damage or dysfunction. This distinction is key. For instance, back pain might be due to muscle strain, nociceptive, or a pinched nerve, neuropathic, and each would require a different treatment approach. Nociceptive pain involves the normal functioning of physiological systems. It becomes a conscious experience through processes like transduction, transmission, perception, and modulation. These steps are like a relay race. Pain signals are picked up, sent to the brain, and then either amplified or reduced. Understanding this helps nurses intervene at different points. Neuropathic pain is sustained by damage to or dysfunction of the peripheral or central nervous system. Ask patients to describe their sensations, such as burning, shooting, tingling, or pins and needles. The patient's self-report is the gold standard for pain assessment. Nurses play a crucial role as advocates, acting promptly to relieve pain, respecting patient values, and minimizing personal bias. Even if a patient looks fine, their reported pain is valid. Nurses must avoid assumptions and respond with empathy and clinical judgment. A comprehensive pain assessment includes location, intensity, and quality. Use pain scales and observe nonverbal cues like facial expressions, leg movements, activity levels, crying, and consolability. These cues are especially important in patients who are nonverbal, like young children or those with cognitive impairments. Tools like the FLAC scale help translate these behaviors into measurable data. Consider the psychosocial aspects of pain. Pain holds unique meaning for each person. Advocate for proper pain control for all patients, recognizing the impact on their emotional and mental well-being. For some patients, pain might be tied to trauma, fear, or cultural beliefs. Being sensitive to this helps build trust and ensures that care is respectful and patient-centered. Assessing pain can be challenging, especially in patients who cannot self-report. Use tools like the hierarchy of pain measures, PAXLAT-C2, and PainAD for seniors and those with advanced dementia. These tools rely on observations from caregivers and clinicians. Look for patterns in behavior, changes in appetite, or altered routines. These often signal pain in patients who cannot speak for themselves. Pain management involves non-pharmacologic interventions and drug therapy, multimodal analgesia, routes of administration, around-the-clock dosing, and patient-controlled analgesia, PCA, are key strategies. Analgesic groups include non-opioid analgesics, acetaminophen, and NSAIDs. Understanding the properties and potential side effects of each group is essential for safe and effective pain management. Monitor patients taking acetaminophen for hepatotoxicity and those taking NSAIDs for gastric side effects. NSAIDs also carry risks for cardiovascular and renal adverse effects due to prostaglandin inhibition. Opioid analgesics include pure opioid agonists, agonist-antagonist opioids, and opioid antagonists. Morphine, fentanyl, and oxycodone are examples of pure opioid agonists. These drugs act on the brain's opioid receptors to reduce pain signals. Each has different onset times and durations, making it important to match the drug with the patient's specific pain pattern. Key principles of opioid administration include determining the appropriate opioid analgesic, titration to achieve optimal pain relief, and using dose range orders for opioid analgesia. Titration means adjusting the dose gradually. This ensures pain relief while minimizing risks like respiratory depression or oversedation. The opioid epidemic is a national emergency. It involves the misuse of prescription opioids and illicit drugs like heroin and fentanyl. Prevent secondary exposure and promote responsible opioid use. Understand the differences between physical dependence, tolerance, opioid addiction, and pseudo-addiction. These are distinct concepts that require careful assessment and management. For instance, a patient who appears drug-seeking may actually have unrelieved pain. Mislabeling them can lead to undertreatment and suffering. Opioid naive refers to patients who are not chronically receiving opioid analgesics. Opioid tolerant refers to patients who have been taking opioids regularly and require higher doses for pain relief. Equianalgesia means approximately the same pain relief. An equianalgesic chart is a guideline for selecting doses for opioid-naive patients and switching between drugs or routes of administration. Drug formulation terminology includes short-acting, modified release, and long-acting drugs. Understand their onset time, duration, and release patterns to optimize pain control. Short-acting drugs are good for breakthrough pain, while long-acting ones provide a steady baseline level of relief. Using both in combination is often the most effective approach. Selected opioid analgesics include morphine, fentanyl, hydromorphone, oxycodone, hydrocodone, and methadone. Each has unique properties and considerations for use. For example, methadone has a long half-life and requires close monitoring, while fentanyl is potent and often used in patches for consistent relief. Dual mechanism analgesics like tramadol and tapentadol work through multiple pathways to relieve pain. This can be beneficial for certain types of pain and patients. Avoid meperidine and codeine due to their potential for adverse effects and limited efficacy compared to other opioids. Consider safer and more effective alternatives. These drugs combine opioid and non-opioid actions, helping with pain that doesn't respond well to traditional treatments, while often lowering the risk of side effects. Intraspinal analgesia involves administering analgesics via a needle or catheter in the epidural or intrathecal space. It's placed by an anesthesia provider, and side effects depend on the drug administered. Adverse effects of opioid analgesics include respiratory depression, constipation, nausea, vomiting, pruritus, and sedation. Monitor patients closely and implement preventive measures. Stool softeners, antiemetics, and careful monitoring of respiratory rate are essential. Always have naloxone available for emergencies. Adjuvant analgesics, sometimes called co-analgesics, include anticonvulsants, antidepressants, and local anesthetics. They can enhance pain relief and address specific pain mechanisms. These are especially helpful in neuropathic pain, where traditional opioids may fall short. They also allow lower opioid doses, reducing side effects. Medical marijuana, cannabis, is a Schedule I controlled substance. Some U.S. states have legalized medical cannabis, but it is still federally illegal. Healthcare providers assess and determine qualifying conditions. The endocannabinoid system plays a role in pain modulation. THC, CBD, and CBN are components of cannabis. Medical cannabis lacks FDA regulation, and nurses' ability to administer it is limited by law. Without standardized doses, patients may experience inconsistent effects. Providers need to guide safe use and monitor for side effects or misuse. A placebo is any medication or procedure that produces an effect because of its intent. Placebos are used as controls in research. Any other use has ethical and legal implications. In clinical care, using placebos without patient knowledge violates trust. Always ensure informed consent and ethical practice in pain management. Non-pharmacologic management is appropriate for mild and some moderate intensity pain. It should complement, not replace, pharmacologic therapies for more severe pain. Techniques like distraction, massage, or repositioning empower patients. and can be used regularly throughout the day to boost comfort. Physical modalities include physical therapy, occupational therapy, aquatherapy, acupuncture, cryotherapy, and spinal cord stimulation. These can improve function and reduce pain. These interventions often restore mobility and prevent further complications. They're a key part of long-term pain management plans. Cognitive behavioral modalities include prayer, relaxation breathing, artwork, mindfulness, meditation, and guided imagery. These can help patients cope with pain and improve their quality of life. They reduce stress, which can lower pain perception. Teaching patients these skills gives them tools they can use independently. Care coordination and transition management involve home care management, self-management education, and healthcare resources. Referrals to home health, hospice, and pain specialists are important. Nurses play a vital role in ensuring smooth transitions, reducing hospital readmissions, and helping patients and families feel supported beyond discharge. Thank you for your attention. We hope this presentation has enhanced your understanding of pain assessment and management. Please subscribe, like, and share for more videos.